Hello, everyone. Welcome to this session on the final day of the PFF Summit. My name is Joyce Lee. I'm coming to you from the University of Colorado, and it is my pleasure to moderate this session on the lung transplant experience. We have three outstanding speakers today that will present, and then followed by a live Q&A. Our first speaker is Dr. Tim Whalen. He is a pulmonologist in Mount Pleasant, South Carolina. He received his medical degree from the University at Buffalo, followed by subsequent training at the University of Colorado and University of Washington. And he is now a professor of medicine at MUSC, where he cares for patients with interstitial lung disease and lung transplantation. His talk will cover everything related to lung transplant, the evaluation, the planning process, and the surgery itself. Followed by that is our next speaker, who's Mike Bilachitz. He is a lung transplant social worker at Northwestern Memorial Hospital. He obtained his master's degree in social work at Jane Addams College of Social Work at the University of Illinois in Chicago, and has been a social worker at Northwestern Hospital since 2011. He carries a certified clinical, he works as a certified clinical transplant social worker and provides psychosocial assessments and services to lung transplant patients and their families. And his talk will cover how to navigate Medicare. And finally, our last speaker is Gary Cunningham. Gary Cunningham is a patient who has pulmonary fibrosis and underwent a lung transplantation. He is from Michigan and continues to live in Michigan. And his talk will be sharing his experience with the disease and the lung transplant experience. He is also one of our PFF ambassadors and will be a great resource to our community. And with that, we will move on to our first talk.
Good afternoon, everyone. My name is Dr. Tim Whalen, and I'm excited to be talking to you about the lung transplant evaluation process, planning for your transplant, and the lung transplant itself. Before we get started, I do always show the different relationships that I have with the pharmaceutical industry. None of this funding impacts this talk at all. I'm a clinical researcher for patients with idiopathic pulmonary fibrosis and spend much of my time helping to develop and design clinical trial research. And so that's much of my consulting. One thing that I am absolutely heavily involved in is organ donation. And as part of that, I do some consulting work for the Sharing Hope of South Carolina, which is the organ procurement agency. So I always like to start my talks with the take-home points so that in case you fall asleep, you get the points right up front, and then I'm going to circle back to them at the end. So referral timing. Early is definitely still better. The individual clinical course of patients with pulmonary fibrosis is highly variable. So we have some patients who do really well for quite long periods of time, and we have others who more rapidly progress. And sometimes predicting that is difficult. One key thing whenever one is being considered for referral is to absolutely be participating in pulmonary rehab, make sure your primary care is all up to date, and making sure that your dental care is up to date as well. Then I'm going to talk a little bit about transplant assessment and the difference between transplant assessment and transplant evaluation. So transplant physicians, we kind of speak a different language. So a transplant assessment is often that first visit, that initial discussion, maybe some initial education, some talking about what transplant is. Whereas a transplant evaluation, that evaluation word to transplant physicians means that you really undergo that full assessment. You get presented at a selection committee, and there's a final determination that's made and shared with you as to whether or not you are a candidate, not a candidate, or perhaps you could be a candidate. Listing for transplant, we're going to talk a little bit about that. If one gets through that process and gets onto the list, we want you to maintain good habits, continue to do pulmonary rehab, get to your weight goals, maintain and improve any modifiable goals, and we're going to spend time talking about that. And then notify the center of any changes in your health. You don't want your transplant center to be surprised when you're on that list. The transplant itself, I'm going to talk briefly about that. I think the vast majority of folks here in the audience are really in this initial phase. And so the transplant itself, a lot of that education is done at the transplant center. But I will talk sort of in broad strokes of how we match organs to our transplant recipients. The key messages after transplant are to take deep breaths, cough, and walk. And one really key point that I want to make several times in this talk is that you absolutely are the decision maker on the team. I'm the medical director of a transplant program, and I like to think that I'm in charge of everything. I think my colleagues would tell you that too. But the reality is I'm not. You as the patient and you as the caregivers, you absolutely are the captains of the team, and we need you actively engaged. And as part of that, you have to do advanced care planning and really understand the kind of things that you want and don't want. And the two of you, the caregiver and the patient, really need to work together with us in order for you to have the best outcome. So those are all the big take-home points. So here's the nitty-gritty details. So why is referral early key? Well, this slide has probably been shown a few times during the summit this year. It often comes up. Clinical progression of pulmonary fibrosis is often very difficult to predict. We have some folks who go slowly over time. We have other folks who have rapid decline. And we have some folks who look like that they're doing okay. And then all of a sudden some event occurs and then there's a really big decline. And we often call that an acute exacerbation of the pulmonary fibrosis. So me as a transplant physician, I'm interested in listing people today, right now, who are high risk for death over the next 2 years. So really the person that I actively put on a transplant list is pretty sick, and I'm really concerned is going to end up in the hospital or in the ICU or at risk for dying over a short period of time. In addition, I'm interested in people who have poor quality of life and really need some help with their daily activities because of their respiratory disease. And finally, I want an individual who is medically able to undergo that procedure and who has the psychosocial support to be able to handle the big interventions that we're going to do and follow through on the plan so that they have a good outcome. So that's who I want to transplant today. So who do I want to meet to undergo that evaluation? So you can imagine it's kind of tough to pick that. So if you look at the top left of the graph here, if I evaluate everybody here, this person who's on the slow decline 4 years later, if I put them through all of their testing, I'm going to probably have to repeat all that testing. On the other hand, if I'm over here on the right side of the graph and I decide I'm only going to evaluate patients 4 years after their diagnosis, well, I'm going to miss a bunch of patients that had opportunities for transplant. So how do I think about when is the right time to assess a patient? Well, basically it comes down to, have you had significant progression of symptoms? If you take a look at how you were feeling a year ago and you're feeling a lot worse this year compared to last year, you're a person I want to talk to. I think you're a person that we should definitely be having the start of those conversations. Even if you're feeling okay, but your physicians are telling you that you have a significant decline in your breathing test, you're a patient that we want to meet because we don't want to miss our opportunity to talk about transplant. Definitely, if you start requiring supplemental oxygen and exertion, that's a sign that your lungs are having a tough time getting oxygen into your bloodstream when they're put under stress. And so we want to meet you. And perhaps most importantly, if a patient is asking about transplant, I would really like to have the opportunity to talk to them to provide the best information possible. There are lots of pulmonologists out there in the community that know about transplant, but really and truly transplant questions and answers, they're really best done by the transplant center because it's what we do all day. And so having an opportunity to talk to patients, I think is absolutely what all transplant centers would want. And by the way, I think that this assessing for transplant, it's tough. The timing of this can be really tough. If we're really aggressive about assessing everybody, we're going to assess a lot of people early. And that can be challenging because we don't necessarily have all that room in our clinics and access. So assessing and the time for assessing, unfortunately, I really do think is one of the things that limits our ability to offer this procedure to everybody. I think we all as a community need to work on getting this assessment time right and really giving everybody a chance. So what is this transplant assessment versus evaluation? So the assessment, again, the transplant centers will do this differently. So not every transplant center has the same approach, but it's, for me and my program and other programs that I'm very familiar with, it's this initial consultation. You've been asked to come, you ask questions about transplant. You're not so sick that we're worried that something really terrible is going to happen to you in the very short term. So we have a little bit of time. Let's go ahead and bring you into the clinic and talk about transplant. Oftentimes, this is about a half a day of testing where we do breathing tests, walk tests, maybe CT scan imaging of your chest. Maybe we do an echocardiogram and assess the function of your heart. And we have you come and talk to one of our transplant pulmonologists. Many programs now, including ours, are doing outreach clinics. So we're trying to do these clinic visits closer to people so that they don't have to travel to the transplant center. That is typically an assessment, not really an evaluation. There is a kind of in-between step, which is the mini evaluation. So many programs will call it the mini evaluation, and that's one that lasts maybe over 3 days. Primary objective, again, of this is to identify big barriers to transplant, and then also to help you modify any risk factors, to get you start working on that, begin that education for transplant, and really to get you to start talking about what kind of things you want or don't want when it comes to transplant. Ideally, if things go well with that first assessment, we would bring you in for a full evaluation. This full evaluation, or the transplant evaluation, this is a very consistent process across all of the lung transplant centers in the United States. And some centers will do this right out of the gate. They'll take a look at your medical records that are forwarded to you. Maybe they have a pulmonologist who's called in and been concerned about how you're doing. So they will just say, let's go ahead and do the full evaluation. That full evaluation is typically the full 5 days of the week, Monday to Friday. You come in, you do multiple physician consultations, including surgeons, transplant pulmonologists, cardiologists, infectious disease doctors, anyone that they might think will add value to assessing whether you're good for transplant. And then we all have multidisciplinary teams that include PharmDs, social workers, financial counselors, pulmonary rehabilitation staff, registered dietitians, behavioral medicine, palliative care, and all of our transplant coordinators who really work on the transplant education piece. We do tons of blood work. We do CT scans, plain radiographs, nuclear imaging studies. The invasive testing that we do, we definitely do heart catheterizations to assess the heart, and we will also do an esophageal manometry and pH impedance test, which is where we're measuring the pressures in your esophagus. And my patients, typically, this is the test that they are not enthusiastic to repeat. It's a small catheter that goes through your nose, down into your esophagus and into your stomach. And then we measure those pressures while you swallow. We have you drink some water and liquid to see how that goes. And then we take that catheter out and we put another small catheter all the way back down into your stomach, and we leave it in there for the next day. And then the best part of it is we try to tell you to act as normally as you can. So eat, drink, do everything you can. And the real reason that we're doing that is we want to see if there's any evidence that you have real significant gastroesophageal reflux that can affect things after transplant. Those two things, the heart cath and the esophageal manometry and pH impedance testing, are probably the two most invasive things, but we definitely poke you, we prod you, we ask you lots and lots and lots of questions. And then we also inundate you with tons of education. So all of our programs have education sessions set up during that week to make sure that we teach you about donors. We teach you about what's expected of you going into the transplant. We teach you about what kind of things to expect from the medications and side effects after transplant. We really do inundate you with the benefits of the transplant, what kind of good things are going to happen to you, and then also a bunch of the risks. And when we get done with that whole week, you go back home, we collect all the data, we get the entire team together, and everybody shares their assessment about you, and we go ahead and we come up with a committee decision of yes, no, or maybe not at this time, we need to work on a few things. That decision, it's a formal decision. It's actually comes to you in a letter. It's clearly written out. And ideally, if we say no, we are absolutely being very clear as to why we're saying no. These are the things that we found that are a challenge for transplant. We don't think that you're going to have a good outcome. Similarly, if we say not at this time, we should be very, very clear about exactly what it is that is holding you back from being listed right away. So the yes means we believe the benefit of transplant outweighs the risk. Yes typically means we're ready to list you. We're going to go ahead and put you on the list. No means that transplant, in the decision of the team, we really don't think that this is going to help you. And we're really, really concerned that it's actually going to make things worse. And we recognize that our patients are very sick and that their options are limited. But unfortunately, transplant's not for everybody, and we can definitely make some people feel worse if we choose the wrong candidate. And then again, not at this time. So I want to talk about this one because I think this is one that can oftentimes really confuse people. So we think you're a really good candidate, and then we have a tendency to say things like you're too well for transplant, or it's too early, or some other thing that suggests that you're not that sick. We will also say that you're possibly a candidate, or we want to improve a couple things. So this too early idea, we absolutely recognize that every single patient that we are doing an evaluation on has severely advanced lung disease. That's the norm for what we see. And unfortunately, sometimes because that's our norm, we can sometimes give the wrong impression that we don't understand how sick you're feeling and how much it's affecting you. That's definitely not what we're trying to imply when we say you're too early. What we are trying to figure out, though, is can we maximize the time that you have with your current lungs? Average outcomes after transplant are about 5.5 to 6 years of survival. So about half of our patients will live at least 5.5 to 6 years. That half has an opportunity to live a lot longer. But can we maximize the time that you have with your lungs right now so you get an even bigger benefit? Can we optimize modifiable risk factors? Fundraising is key. Many of our patients are relocating to the transplant center for their rehab and for the transplant procedure. Can we make things that are acceptable go from acceptable to ideal? And so oftentimes we're talking about weight in that. Can we make you stronger? Can we make you physically stronger? Can we make you mentally stronger? Can we really make you mentally ready for transplant? These are all reasons to say, we think you're great, but we want to wait. We want to wait before we actively list you. So possibly a candidate is many of the same types of ideas. We think you're a good candidate, but we're a little less sure if we can modify some of the risk factors that we're worried about. So this might mean, hey, do we have to put in a coronary stent to make sure your heart is okay? Do you have some carotid disease that we want to treat? Do you have really bad gastroesophageal reflux that we believe we need to treat now rather than later? So oftentimes, possibly a candidate is associated with this idea that we need to more optimally medically manage you. We also might be really concerned that you just may not be able to follow through on the modifiable risk factors that we want to try to optimize. And so this can be like caregiver plans. Do we have a really good, strong caregiver who can help you? Can we achieve the acceptable weight? It's a lot of weight that you got to gain or lose. Maybe you're really, really weak and we're worried about how well you can achieve that. So the possibly a candidate means that the transplant center themselves is really wondering, are you going to be able to achieve what we need you to achieve? And key, again, a key component to this is your decision making. So yes, I believe that the benefit of transplant outweighs the risk. Nope, transplant's not for me. And then I often will get a third thing that like, I really, really want a transplant, but I don't think I need it yet. So that I think I want one, but I really think a key thing to make sure that all of you are thinking about, whether you're thinking about transplant or not, is advanced care planning. Having a good conversation with your transplant center team about what really is the likelihood I'm going to get in trouble. Make them tell you, we're really worried about you over the next 6 months. We're really worried about you over the next year. We're really worried about you over the next month. Make them tell you how much they're worried about you. That's a fair question for any physician that's taking care of you. And then I think as a part of that, I think you really have to be open and transparent, not only with yourself, but with your caregiver or your family members who are going through this with you about what kind of things you want and don't want. The reality is, if you are seeing a lung transplant center, if we are going through this process, we are going to tell you that we are going to want to do everything that we know how to keep you going. Even when things look bleak, we will hook you up to every machine. We will put you through every kind of procedure that we know how to do. We will do all of it because we know if we can get you to the other side, you really can have a really good quality of life. And sometimes it can be really tough. So we are going to want every opportunity to do that. We need you on board for that kind of treatment. If you really don't feel like that's something for you, you need to ask questions. You really need to make sure that you're understanding what the teams are talking to you about. You really need to be able to answer that question. Is transplant for you or not? So again, you are the key decision maker. So before you go for that assessment, pulmonary rehab is key. I need you to demonstrate commitment and adherence, improve your strength, quality of life improvement now. It's key for follow-up to transplant. Going to your primary care doctor and optimizing your medical conditions is key. And dental care, getting that is key. So on the list, so I'm going to kind of speed up and go through these other portions because I think the vast majority of what you all in the audience are focused on is the first part. But once you're on the list, you really need to ask your transplant center, how long do they think you're going to wait? You need to set goals. Set those goals for what your pulmonary rehab maintenance program is going to be. Ask the transplant center what those goals are for you, and then work on that fundraising. Make sure you've got plenty of funds and resources to help when we call you in. We definitely want you to continue your medical management, and we really want you to read those transplant education materials because it's key that you ask questions. And so what do you need to really get ready? Well, you need to have a go bag. You need to have clothes for the trip. You need to have medications ready to go. You need to have your travel plan all clear. That car always has to be working. It always has to be full of gas. Your cell phone always has to be on. You need to have oxygen ready to go for the trip. And where is the caregiver going to stay once they call you in? So what hotels are you going to call to try to stay at? What's your plan for the caregiver? Because especially with COVID, staying in the hospital is not always an option. And honestly, staying in the hospital as a caregiver is not a comfortable way to go. I really don't recommend it. Caregivers, we often don't talk about caregivers and what they need to do. Caregivers need to have their FMLA and time off really set up and ready to go and be able to notify on a moment's notice. You need to make sure that your home is being taken care of and that you've got a plan if you have to relocate to the transplant center. You really need to know what kind of support you as the caregiver can get because you're going to be really exhausted and tired too. And oftentimes having a support person for you is extremely helpful to allow you to provide better caregiver support for the patient who's going through everything. So what to expect after transplant? So I think the vast majority of you will learn what to expect after transplant as you go through a transplant evaluation. But really the key things after that transplant, every transplant center is going to tell you is kind of a mantra. Take a deep breath, make sure you cough, make sure you walk. That's from day one all the way through your time while you're rehabbing at the transplant center to the time that you get home. Throughout this entire time, we're teaching you more and more about transplant. We're telling you to take a deep breath, to cough, to walk. We're teaching you about your medical management so that you can take care of yourself, and your caregiver is definitely a key component of making sure you get all your medications and you understand everything. And then we're telling you to take a deep breath, cough, and walk, and have an opportunity to live your second chance to the fullest. And our patients do many great things, from helping to take care of their great grandkids and their grandkids, to climbing mountains, to running, to biking. We really have a full spectrum of what folks do. So the key take-home points: referral timing, it's better to think about it early than it is late. Transplant assessment is different than an evaluation, and an evaluation will give you a formal decision. If you're not hearing a formal decision, you really haven't undergone an evaluation at a transplant center. You definitely are a key part of the team, and you need to do advanced care planning and know what kinds of things you want and don't want for your care. And once you're listed at a transplant, you want to make sure that you take every opportunity to modify any risk factors that are modifiable for the better. And then again, after transplant, we want you to live your life to the fullest and take that second chance as far as you possibly can. Thank you very much for your time.
Hello, my name is Mike Bilachitz. I am a licensed clinical social worker, and I work for the Lung Transplant Program at Northwestern Memorial Hospital. Today's presentation will be an overview of how Medicare insurance coverage interacts with patients that are going through a lung transplant evaluation with the goal of being listed and transplanted with either a single or bilateral lung transplant. A little bit about me. I received my graduate training at the University of Illinois at Chicago, Jane Addams College of Social Work. I joined the case management department at Northwestern Memorial Hospital in 2011, and I worked on the general medicine floor, which was a majority of discharge planning and providing counseling to patients on a general medicine floor. I joined the Northwestern Medicine Lung Transplant Program in 2015 and provide pre and post-transplant support to many patients. We've successfully transplanted over 200 patients here at Northwestern. Our volume has gone up significantly over the last year and a half. We have performed a high number of lung transplants for COVID patients. I only bring that up because that has been an educational opportunity for us in educating patients that were not expecting lung transplants on how insurance coverage covers the ins and outs of such a procedure. I have no conflicts of interest to disclose. I receive no compensation from any other entity other than Northwestern Memorial Hospital. I'm going to start with a basic overview of what Medicare is. Most people are familiar with Medicare as health insurance for people that are 65 and older. There are other categories in which a person may qualify for Medicare, most commonly if they've been on Social Security disability for 2 years. In the literature, you'll see it referred to as 24 months often, with the 24-month being the time when somebody could apply for Medicare despite being under 65. Medicaid is often confused with Medicare. So a quick overview, Medicare is a federal health insurance plan, whereas Medicaid is a joint federal and state program, which is administered through the states. It is possible for people to have both Medicare and Medicaid. However, this talk will be focused on Medicare itself. Medicare is not a single plan. It's made up of separate parts that can be a little confusing in understanding, so I'm going to break those down. Medicare Part A is hospital insurance. It covers inpatient care. Anytime somebody gets admitted to the hospital, Part A is covering the majority of that inpatient care. That part also covers care in skilled nursing facilities, acute inpatient rehab hospitals, as well as hospice care and some home health care. Part B of Medicare covers outpatient care. So this would be your clinic visits, your outside procedures, anything that's happening on a same-day basis and doesn't involve an overnight stay, as well as home health care, durable medical equipment, and preventative services. Those are all covered by Part B. Part D is a separate part of Medicare, which is in fact a standalone insurance plan. Think of Part D as D for drug coverage. Parts A and B do cover some medications, but the vast majority of prescriptions will be covered by a Part D Medicare drug plan. A Medicare supplemental insurance plan is an extra insurance plan that somebody can purchase from a private company that's going to pay the share of costs that Parts A and B do not cover. Parts A and B of Medicare only cover 80% of the costs that I just outlined. By getting a supplemental insurance plan, that will pick up the remaining 20%, and that is what you would consider somebody to be fully insured when it comes to being prepared for the costs of a lung transplant. You may also hear about Medicare Advantage plans. These can also be called Part C plans. The difference between original Medicare and Medicare Advantage is pretty big. Original Medicare includes Parts A and Part B. Part D is an optional prescription plan, and you can use this at any doctor or hospital that takes Medicare anywhere in the US. Your Medicare supplement follows those same rules. So the pro of having original, straightforward Medicare is that there's no network, there are no prior authorizations required for services. However, it does cost a little more money than what most people expect once you add on a Part D plan and a supplemental plan. Some of the advantages of a Medicare Advantage plan would be that all of your services are bundled into one private insurance company. In this way, you don't have to think about Part A, B, D, and a supplement as separate entities. All of those benefits are being covered by one private insurance company. So think of your Blue Cross Blue Shield, United Healthcare, etc. Many people sign up for Medicare Advantage plans with the promise of cheaper out-of-pocket costs. Many of those plans have very low monthly premiums, even $0 premiums in some situations. The trade-off with an Advantage plan is that you're back to having a network. Just like when someone has employer-based coverage or private insurance that they've purchased through the marketplace, there's in and out-of-network benefits. And there might be higher out-of-pocket costs than with original Medicare if you are a high utilizer of healthcare, which transplant patients definitely are. So there are pros and cons to both original Medicare and Medicare Advantage, and that is something that a social worker at any transplant center should be able to provide some counseling on for each individual patient and family. Enrollment in Medicare varies on the situation. For people that are turning 65, there's an initial enrollment period. There are also special enrollment periods, which are too numerous to list here. There's also an open enrollment that occurs every year from October 15th to December 7th. I would recommend that you look on Medicare.gov, and there will be a list of resources at the end of this presentation to determine, based on your age and whether you're on disability, on whether you are currently in an enrollment period where you can purchase or you can enroll in Parts A and B, a prescription plan, or in a supplement. You can tell that a lot of this is pretty confusing information. A fantastic resource for people in Illinois is the Senior Health Insurance Program. This is a free statewide counseling service for people that are looking to enroll into Medicare or make changes to their Medicare. I would recommend simply Googling Senior Health Insurance Program Illinois, and that'll take you to their website. And those counselors are usually affiliated through local community service agencies. So these could be local area agencies on aging or other community-based organizations that can walk you through understanding the different parts of Medicare and help you navigate the website to see what your options are without being biased. They're not going to try to sell you on any particular plan, simply help you understand based on your situation what changes you're allowed to make for Medicare. Speaking specifically about lung transplant, Medicare will cover an evaluation for a lung transplant without any prior approval or authorization, assuming that the transplant center is Medicare certified. Here at Northwestern, we've been Medicare certified for several years. So a patient can be seen, that's can be seen for a consultation with a transplant physician with just Medicare Parts A and or B. The consultation will be to determine whether someone is enough of a candidate for transplant to begin the evaluation. In order to do the full evaluation, it is recommended that our patients have a full insurance, including a supplement or a secondary insurance, because the costs of the evaluation can be quite high if you're not fully covered. You may also have a Medicare Advantage plan. If you do have a Medicare Advantage plan, that would need to be approved by our transplant center before you're seen for the consultation. And we would need to obtain an approval from the Medicare Advantage plan, like I say, for the evaluation, as well as for the listing, meaning when someone actually is placed on the transplant list. With traditional Medicare, we do not need a separate approval in order to list someone for the transplant. All of the post-discharge and outpatient care, which is quite heavy at first, especially for the first year after lung transplant. All of that should be covered as long as your Medicare Parts A and B, as well as your supplement is always active. That is always going to be covered. To try and not overcomplicate this, the bottom line is if you're a patient or you are a patient or a caregiver of someone that is being evaluated for a lung transplant, you should not expect to be blindsided by catastrophic medical bills, which is kind of everybody's worst fear. As long as you have the right coverage in place up front and as long as the right authorizations have been received. Keep in mind that transplant-related costs that Medicare doesn't cover may include things like travel to and from your transplant center, parking, tolls, lodging. Some of our patients are staying at local hotels. The majority of insurance plans don't cover those kind of costs, and we know that Medicare does not. However, for the medical care itself, if you have parts A and B, as well as a supplement and a prescription plan, you will not be hit with $1 million transplant bill. One thing to be aware of is that transplant patients do have a lot of hospitalizations and readmissions. So it may be useful to educate yourself or to let your patients know that there are lifetime reserve days and Medicare days that are well explained on the Medicare website, and to become a little more knowledgeable about that part of Medicare coverage. It's important to understand that anybody that has Medicare at the time of their transplant will always be eligible for Medicare Part B to cover their immunosuppressant medications. These are the medications that are used to try and prevent rejection of the transplanted lungs. There's a special carve out in Part B for this class of drugs. So as long as you have Part B and you have a secondary or supplement insurance, your anti-rejection drugs will always be covered 100% with a $0 copay. It's important to know that some pharmacies, however, may not be aware that you had Medicare at the time of your transplant, and they may actually try and bill the Part D plan, at which point the Part D plan will say, no, this needs to go through Part B. So sometimes there's a little bit of education to be done with the pharmacist, making sure that they're billing the proper part of your Medicare for anti-rejection drugs. All of the other medications, anything that's not for rejection, there's probably about 15 to 20 different prescription medications that our lung transplant patients take in various forms. Most are pills, some may be inhaled or nebulized, some may be through an IV and a PICC line. Most of these are long-term after transplant and many are lifelong. The majority of those drugs are going to go through your Part D as in dog plan. This is where most Medicare patients will see a significant increase in their out-of-pocket costs because a lot of our medications are relatively new and they are considered specialty drugs. Common examples would be Noxafil, which is a medication that's used to prevent fungal growth in transplanted drugs, or Granix, which is a medication used to treat a condition called neutropenia that often occurs in our patients as a side effect of other medications. When you're going through a prescription plan like a Part D plan, there's a lot of prior authorizations. Your transplant team may need to do a lot of appealing. There may be a lot of denials. Some of the medications are being prescribed, I'm not sure if this is the right term, off-label or lacking FDA approval, or it just may be due to cost. Bottom line for prescription coverage for Medicare patients, in general, our patients report about $5,000 to $10,000 yearly in out-of-pocket costs for the non-rejection medications on Medicare. How do we plan for affording those out-of-pocket costs? There are a few resources that patients and caregivers can look into as they think about whether transplant is right for them. There is a Medicare Part D extra help program through Social Security. There is a Medicare savings program for patients that do have Medicaid in addition to their Medicare. Outside of those, it's a lot of planning ahead. I strongly recommend that anybody considering lung transplant start thinking about forms of assistance from family or utilizing savings, as well as thinking about starting a transplant fundraiser. There are organizations such as Help Hope Live and National Foundation for Transplants, which can help patients and families start fundraising campaigns. And the funds that are raised in those can be used for medication costs. I also recommend that any patient with Medicare, if they receive a transplant and if they have any difficulty affording their medications, that they reach out to the transplant program and work with a social worker such as myself to research any patient assistance programs through the drug manufacturer, copay foundations, and other charitable organizations. There is not a guarantee that there's always a source of support in lowering costs of drugs after transplant, but it's a good idea to reach out and do some of that research to see what's available. Many of our Medicare patients are on at least 2 patient assistance programs because the high cost of their copays for some of those medications I mentioned earlier. Some of our patients they forego their insurance for certain medications and use a program such as GoodRx, which is a discount program where you're paying out of pocket. Individuals that are referred to a lung transplant program should understand how their Medicare coverage will pay for their inpatient and outpatient care as well as their medications. From our perspective, to be considered fully covered for lung transplant, a patient should have parts A and B, a Medicare supplement or a secondary insurance plan, as well as a Part D prescription plan. The alternative would be having a Medicare Advantage plan. Prospective patients should plan financially and ask to speak with a transplant social worker during their evaluation to better understand the specifics of their own coverage. This is a resource slide. Medicare.gov and MedicareInteractive.org are fantastic kind of gospel truth resources for going into detail about what I've talked about. The Senior Health Insurance Plan and Extra Help are on there. Great resources of education for lung transplant, not just from a financial standpoint, but in general, include the Lung Transplant Foundation, Second Win Association, as well as UNOS and the fundraising organizations. Thank you very much for your time today, and I wish you well on your transplant journey.
Hello, my name is Gary Cunningham. I'm a pulmonary fibrosis survivor. I got diagnosed with this disease 10 years ago and have got quite a story to tell about my journey with this disease. It started in the fall of 2011 when I was having problems. Actually, it started even before that, almost a year before that, when I used to walk up the 10 floors every day to my office just for exercise and things like that. And in late 2010, early 2011, I started having problems getting to the top of those stairs. My legs were burning. I thought maybe I had some sort of circulatory problem or heart problem or something like that. So I finally called out to my primary care physician and went in to talk to him about it. And sure enough, he sent me over to a cardiologist who checked me out 4 ways to Sunday and said it wasn't a circulation problem that I had at all. Wasn't certain what it was, but it wasn't my heart and it wasn't my circulation. So I still kept having problems with it. So I went back to my pulmonary care provider and we started talking about family history and things like that. And sure enough, I said, well, my mother died of pulmonary fibrosis, and I think my grandfather had lung problems too. So maybe I have some lung disabilities. And he sent me over to a very, very good pulmonologist at Henry Ford Hospital in Detroit, who put me through a long series of tests, but very quickly decided that I indeed had pulmonary fibrosis and gave me that diagnosis. And since my mother had already passed from that disease, I knew pretty much what that meant. I knew that there wasn't a cure for it. I knew that people died from it fairly quickly. I knew that the prognosis was not good. I didn't need to be told that. I made a couple of decisions as a result of that. One decision I made was that I wasn't going to die at the office. So I made some arrangements for taking an early retirement. I also decided that I was going to fight this disease and do whatever I could to get a better outcome than my mother had. And so I ended up scouring the whole country for doctors, treatments, treating facilities. I was in contact with every major pulmonary care facility in the continental United States, including University of Pittsburgh, Duke University, Cleveland Clinic, Mayo Clinic, National Jewish Health, University of Michigan, and everything in between. One of the things that I was trying to do, number one, was get a second opinion on whether or not I really had pulmonary fibrosis or not. deep down in my heart, I kind of knew I did, but I was hoping that maybe somebody made a mistake. So I ended up going to other places and getting second and indeed third and even fourth opinions on that. And they all consistently came back the same. They all said that, yes, unfortunately, you have pulmonary fibrosis. And more importantly, you have kind of a strange type of pulmonary fibrosis. Yours, for some reason, has started in the upper lobes of your lungs and are traveling down, which is atypical for this disease progress. Most people get it in the lower lobes of their lungs and it tends to move up, but you're the exact opposite. That didn't seem to matter on the progression of my disease so much, but what it did do was it ended up precluding me from going to participate in clinical trials. I have a perfect batting record of trying to get into clinical trials. I think I tried to get into 12 different ones at about 8 different medical facilities and was rejected by each and every one of them. And the reason is because of the nature of the progression of my disease. Had nothing to do with anything else, no comorbidities or anything like that. It simply was they didn't want to put somebody with an atypical presentation of the disease in their study. And they were quite candid about it. And upon reflection, I understood why they did that, but unfortunately that meant that I didn't get to participate in any kind of clinical trials in the early days. Finally, a couple of drugs came along, pirfenidone and nintedanib. And I tried both of those diligently. In fact, pirfenidone I tried on 3 different occasions. Nintedanib only one. And I had the same reaction with all of them. I either had horrible sun problems with them. With one of them, I remember I got horribly sunburned the first time that I went out and drove the car, literally through just the windshield of the car. I got a horrible sunburn. I also ended up with acute gout attacks from one of the drugs. So as a result, I couldn't use either of the medications that came on the market as well. And during this time, obviously, my situation was getting worse. I finally had to be put on oxygen. My oxygen needs started growing precipitously. I started off at 2 liters on a portable concentrator, and by the time I got transplanted, I was on 12 liters of continuous liquid oxygen at home. And that was the only reason why I was able to stay at home, was because I was able to get liquid oxygen delivered to my house after a long fight with the insurance companies. But I did make a decision that I wanted a lung transplant early on in the process. And that was probably one of the best decisions I made, because they told me I had to do some things in order to be able to be treated as a lung transplant patient. 1, I needed to get involved in support groups. 2, I needed to get involved in pulmonary rehabilitation. And 3, I needed to start making certain that I had a positive attitude about the whole process and that there was light at the end of the tunnel, so to speak. And by doing those 3 things, really helped me get through this whole process. Also along the way, I got involved with the Pulmonary Fibrosis Foundation. That was clearly the best source of information that I had, probably of almost anything. Between Pulmonary Fibrosis Foundation and the support group that we were involved in, those were probably the 2 best sources of information for me during that time. And more importantly, it was a great source of support, just emotional, educational, even economic, because Pulmonary Fibrosis Foundation even supported our support group with some small monetary contributions to make certain that we were able to hold those meetings in a nice place and pay some rent to the nice church that accommodated us. And at any rate, I made that decision to get a transplant because the drugs weren't doing me any good, and I wasn't being allowed to participate in any clinical trials. So initially, I enlisted at the Henry Ford Hospital in Detroit, which has a very good pulmonary program and is one of the first institutions in America that successfully did a lung transplant, I believe all the way back in 1991. I thought that was a pretty good program, so I was accepted into their program. This was in the early part, either late 2016, late 2016 or early 2017. I was on the transplant list for about 2 years at Henry Ford Hospital and decided that I needed to get more proactive about it. So I made a request. I was the first person in the state of Michigan to make this request, apparently. But I wanted to be listed at 2 different places in the same state. We have 3 wonderful pulmonary facilities here in Michigan with the University of Michigan, Henry Ford Hospital, and Spectrum Health in Grand Rapids. And I made a conscious decision to be listed at both Spectrum and Henry Ford Hospital. And I needed their permission to do that. And they finally gave it to me. They gave that to me in late June of 2019. And I went over and got listed very quickly over at Spectrum Health in Grand Rapids. And so I was dual listed there. And 10 days after I got listed at Spectrum, I got a call that they had a perfect match for a double lung transplant for me, and that it was time to get in the car and go receive them. They literally saved my life. At the time, I was on 12 liters of continuous oxygen, completely bedridden at home, not doing anything. My wife drove me over there, and we did a wonderful, wonderful job. The surgeons were great. The facility was wonderful. They saved my life. I can't say enough about what a wonderful experience it was and how good it was to get through it. I got through the ICU in less than 48 hours, and I got discharged within 9 days. And the only reason for all that good work was because I had done all the pulmonary rehabilitation work that I was asked to do. I took good care of my health. I did everything that doctors asked me to do, and that's why we got a really good result. And I'm here today to tell you about it and to encourage you that no matter how bad this disease gets for you, there's always hope. There's always something out there. They're either going to come up with a cure, a new drug pyramid, or better procedures for lung transplants. But there's always hope. So keep hope in your thoughts and in your prayers, and you can beat this disease. I did it. So can you. Thank you for listening to me.
Hello, and welcome to the live Q&A portion of this session. We just listened to some fabulous presentations, and we have numerous questions, so we're just going to dive right in. And we are not able to answer specific questions to your health or your medical problems, but we'll try and adjust some of the questions to be more broadly relevant to other members of the audience. Okay, Dr. Whalen, I'm going to start with you here. There's the first question that came in had to do with experience of lung transplant centers across the U.S. Is there a way for patients to understand differences in lung transplant centers?
So it's, honestly, I think it's really difficult. I think Mr. Cunningham's comments actually kind of speak to that a bit. Transplant centers tend to ebb and flow a little bit. And the number of transplant specialists in the United States is kind of limited. And so people sometimes do pick up and move. And so what you'll see is transplant centers that have a long history of transplant, they may not necessarily be doing a lot of transplants this year, whereas in 2 years, all of a sudden their volume really picks up and things are changing. So I do think it can be difficult. The good news is that in order to become a lung transplant center, in order to be a Medicare approved lung transplant center, there's a whole set of criteria that folks have to meet. And I think that there are absolutely resources that you can look at. The SRTR is one of them in particular to look at outcomes. But I really encourage people to look and ask specifically, what's the likelihood you will get transplanted if they put you on the list? If we don't get you transplanted, you don't get a chance to have those outcomes. So I think that's a key thing, no matter where you go.
Great. And just to follow up on that, there have been several questions, again, just asking about appropriate timing of transplant. When should patients start getting that assessment? Are there changes in lung function that determine transplant eligibility or the timing of lung transplant? And how do you consider the, the expected longevity of the transplant in relationship to the timing of the transplant?
Yeah, so as I mentioned, I think it can be really difficult to do the very last thing. It's hard if people can progress quickly, and so my concern is not giving you an opportunity. So I feel like it's a really good idea for people to talk to transplant centers early, or at least start investigating and getting educated about transplant early. So even if you're just newly diagnosed, right? You're newly diagnosed, you're doing okay, you don't require oxygen, still it's an okay thing to learn a bit about transplant. In particular, for patients that will list, if you require oxygen at rest, typically with pulmonary fibrosis, that's not a good thing. Also, if you require oxygen just with exertion, so you do that walk test, that's also a time where we really want to start evaluating people. And in terms of declines in breathing tests, I think if you have noticed a significant decline in your lung function or your ability to do things over the past year, yeah, we need to talk to you, and you need to talk to your physicians about what it is that they think is going to hold you back from a transplant or get you there. And I also think the best thing, one of the best things I think that Mr. Cunningham said was that getting prepped for transplant, it really helps you be a better medical patient just in general with pulmonary fibrosis. So that's the huge advantage to it in my mind.
Great. Gary, I'm going to actually ask you the next question here. How did you find the support group to help you through that lung transplant process? Were there specific benefits to that you can share with our audience?
There's quite a backstory on that, actually, in our case. I didn't find it, my wife did. She found it online through, I believe it was the cystic, one of the other foundations. It was posted online, and it was really early after I'd been diagnosed. And she said, I found this support group, and I think we'd ought to go. And I said, I don't want to go to a support group. I got pulmonary fibrosis. I got to find the right hospital. I got to find the right doctor, surgeon. I got a lot of other things to do. I don't need a support group. But it was about 3 weeks off before the next meeting was, and she finally said, I'm going, whether you're going or not. I finally said, well, can't let you go by yourself. So I kind of begrudgingly went to that first meeting, and it was phenomenal. It was the single best hour of time that she and I spent early on in this whole process of getting involved in the support group. And I tell patients now that there really are only 3 things that you really, really, really must do with this disease. One is obviously get a good physician, a good pulmonologist, somebody that you trust, somebody that you got confidence in, because that person's going to help you save your life. The other thing is get involved with a good support group. It's really important. And the third thing I tell people is get involved in pulmonary rehabilitation early and often. If you do those 3 things, you've got a much better chance of having a good outcome of this disease.
Great. Thanks, Gary, for those insights. I'm going to now go back to Mike here about the insurance world and preparing financially for lung transplantation. There are 2 questions here that I'm going to ask back to back here. One of our audience members was wondering if you could clarify out-of-pocket costs related to the lung transplant medications, which are included and which are not. And then also the timing of fundraising. When should people start that process?
Sure. I would say I'll start with the fundraising. I think it, first of all, probably depends on what you're fundraising for and whether any part of your fundraising is tied to any needs pre-transplant. Many people are hesitant about the idea of fundraising in general. There's a lot of emotion tied up with our egos and our sense of independence and asking others for money, and kind of being humble about the fact that we live in a healthcare system that has a lot of holes. And unfortunately, transplant comes with many out-of-pocket costs. And so just getting over that hurdle, so probably just starting to think about it and research it is probably a good thing to do as soon as you start thinking about transplant. To actually begin the fundraiser, in most cases, individuals will wait until they find out whether they're a candidate to be placed on the list in order to avoid having any funds that were raised that then aren't being used for that purpose. The transplant organizations that do fundraising are not able to return those funds if someone is not a transplant candidate. So if you do that before you know whether you're going to be on the list, you kind of run the risk of losing access to that money. However, it does remain in funds for other lung transplant patients. GoFundMes and other types of less structured fundraisers may not have that issue, but most people will wait until they're on the transplant list. The question about reiterating the cost, I wish I could sit here and say, this is the cost, this is what you should expect. The fact of the matter is immunosuppressants are much more straightforward because they're being covered by Part B at 80% and by a secondary or a supplement for the remaining 20%. So the really important anti-rejection drugs in the vast majority of cases, you shouldn't worry about. However, the antifungals, antivirals, the more specialty drugs that our transplant patients take by virtue of being heavily immunosuppressed, and lungs are the only organs we're transplanting that are open to the environment, so the risk of infection is just so high. So it's really that class of drugs that's going to be more expensive. We can't predict exactly what that list of meds is going to be. Lung transplant patients develop other long-term or short-term conditions as a result of side effects of other medications that they're taking. So it would be impossible to just say, this is a list of meds and this is what they cost. So really what you want to think about is, it's based on the prescription plan that you have through Part D. Is that particular medication on the formulary? What tier is it under? Is it preferred versus non-preferred, generic versus brand, or specialty? It's that specialty tier that gets you, because that's usually a percentage cost of the drug itself. And then what phase of the coverage you're in, because Medicare Part D has this really fantastic, very, very logical, I'm being sarcastic, donut hole process where the cost of one drug changes from January to March to December. I wish I could give you a straightforward answer. In my experience, folks that don't utilize any assistance programs or copay cards or things like that, and usually most people, if they're under certain income, are using those things, but if they're not, I think it's safe to say, unfortunately, we're looking at anywhere from $5,000 to about $7,000 or $8,000 out of pocket total when all of those things are added up, especially for folks who develop other chronic medical conditions.
Great, thanks, Mike. And I think we're gonna wrap up the Q&A with some questions to Dr. Whalen again, but focus more now on care after transplant. Are there things that you recommend to keep the lung transplant healthy? Do you recommend that patients live near their lung transplant facility? What are things they can expect after transplant?
So I was going to say, you always have to listen to your doctor. But I think, no, I think really, good, healthy habits, right? And so pulmonary rehab, we say it over and over again, but exercise, the COVID pandemic has just been really excruciating, I think, for all of us. But all of those principles that we were teaching our patients for years, wash your hands, be very careful about who you're around, be very careful about gatherings, particularly in the wintertime and indoors, because we were worried about influenza. All of those types of things are, I think, realities for us, throughout the year now. In terms of, I saw one question about, are there like bad habits? So, early after transplant, we have to be careful about the immunosuppression. So we do have some restrictions on some of the types of things that we want you to eat, not too dissimilar from pregnant women. And then we get worried about if you're swimming in, ponds and things like that. But for the general rule, I would tell you, I encourage my patients to fully live their lives. That's why we do this. I want you to live your life. So I tend to be the guy that's like, go do what you want to do. It's a really good thing.
Oh, wonderful. I think that's a great way to end this session. Thank you to all of our speakers for such an informative session on the lung transplant experience. Just a note to our attendees, you'll be receiving a survey on this year's summit on Monday. We would love to hear your feedback, and we value that, and it impacts our next year's programming. So thank you again, and enjoy the rest of the summit.